Hi, everyone. Thank you so much for joining us. We're going to get started here in just a moment. We're just letting everybody in, and I'll do introductions in just a second. For those of you that are here, if you want to pop into the chat to see how that's working and let us know where you're from, we'd love to see where around the country we have folks joining us from. I'll start by introducing myself. I am coming to you from the very rainy North Carolina area, Davidson, North Carolina. My name is Susan Boas. I'm the president of the board of directors at the International OCD Foundation, who's hosting tonight. And I am also the executive director for the Pandas Physician Network. So I've got both of those titles up on the screen, and I'm going to host tonight. And I'll introduce our guest speakers, which I think some of you are going to be incredibly excited about here in just a moment. Hi, Sean from Seattle. Oh my goodness, we have got West Coast in the house. Long Beach, California, Portland, Oregon, and Bend, Oregon. I don't know what's going on in the West Coast, but you guys are here on time. That is excellent. Hi, Kim. We've got DC, finally, East Coast. I was starting to wonder. We've got Indianapolis, New York. Hi, Carol. Oh, hey, Wendy. I know you. Chicago. How you doing? Las Vegas, back to the West Coast. What kind of the West Coast? Nevada showing up. Georgia and Tennessee. Got some Southeast representation joining me. I appreciate that. Pennsylvania. Oh, all the way from the UK. Hi, Rachel. Thank you so much for joining us. I don't know what time it is there, but that is greatly appreciated. Martha, I am literally a stone's throw from you in Cornelius. So I will not use those earlier storms as an excuse if I cut out, because if you have power, I have power. Ontario, Canada. We got New Hampshire in the house. Hi, Christine. Winnipeg, Canada. Got a couple Canadians. Another UK. Hi, Georgie. Hilton Head, where we all wish we were. Hi, Shelley. New Jersey, New Hampshire, Oregon, more Oregon. We are very heavy on the Oregon group tonight. We have the International OCD Foundation has a great affiliate out in Oregon. If any of you are interested in an affiliate, I see a ton of you from Oregon. New Hampshire, Maine, Maryland, North Carolina. Hey, Wilmington. I'm from Jacksonville, North Carolina. I'm from the other side of the eastern part of North Carolina. And a couple more Massachusetts and even Arizona. Very nice. All right, I think we've got enough of you joining us. Please keep posting where you're from in the chat so we can watch where all we have people attending from. And I am going to go ahead and introduce our speakers. I'm getting a background echo. Thank you for letting us know. We'll ask our tech people to help us out with that. All right, we're going to start with Dr. Sydney Rice. Dr. Rice, hi there. She is a professor of pediatrics at the University of Arizona, holds a bachelor degree from Stanford, a doctorate in medicine from the University of Arizona, and a master's degree in health evaluation sciences from the University of Virginia, so all over the country. She completed a developmental behavioral fellowship at the University of Virginia and is an active clinician and researcher. And she is the co-director of the Childhood Autoimmune Encephalopathy program at UA. So welcome, Sydney. We're so glad you're here with us tonight.
Thank you, Susan. Thank you for having me. I'll tell you a little bit about our program, and which is both research and clinically based. I'll talk about research first, which is we have a basic science research program primarily focused on looking at the microbiome using mice with PANS and Pandas. We have a very active clinical program, which is, and the research side of that is also looking at the microbiome in children and we're looking forward with Dr. Williams as well. There's a group of us across the country who would like to look at imaging and hopefully collaborate on a large registry that we can use to connect both ourselves and our families. Clinically, we started our program in 2016, so we're kind of newbies in this whole thing. And we've learned a lot over the years. I would say it feels like almost every 3 months we're a different clinic, just because we keep pushing forward as much as we can. We have the clinicians in our clinic and we see patients together 1 day per week. We have a child psychiatrist, 2 psychologists, an immunologist, and myself. I'm a developmental behavioral pediatrician, as well as a full-time nurse who this is all she does is help us communicate and support families. I'll stop there.
So exciting, Dr. Rice, to hear anyone talking about the microbiome. So I'm sure we'll have a lot of questions about that as we go through. I feel like 10 years ago, everyone would have rolled their eyes if we started talking about the microbiome and OCD. And now it's something that a lot of researchers are becoming very interested in. So I look forward to hearing more about that tonight. Now I'll give an introduction to Kyle. I've known Kyle Dr. Williams for a long time. We had a bet ahead of time of whether I could say Dr. Williams for this whole call. So I'm going to try very hard to stay professional. My apologies, Kyle. Dr. Williams is the Director of Pediatric Neuropsychiatry and Immunology, the research program at Mass General Hospital, and an instructor in psychiatry at Harvard Medical School. Dr. Williams' primary clinical and research interests involve the intersection of the brain and the immune system, and in particular, the psychiatric and behavioral consequences of those interactions. Kyle, would you like to tell us just a little bit about what you are working on at this point?
Sure. Yeah. So our program is based in child psychiatry and then also in infectious disease. And I work with Dr. Mark Pasternak and Dr. Dan Geller as well. We started in 2013 and have seen probably collectively, I think probably 1,200 kids for an evaluation of PANS and Pandas since 2013. And we started also with the purpose and the goal to also do research on this disorder to try to move it forward and I think try to break down some of the persistent questions about this, both that we have about how best to treat it, but then also these questions that I think people are parents who have this disorder are fielding from their own pediatricians and other folks that they're about kind of whether or not they should investigate this or how to treat it. So we've tried to both provide treatment and move kind of some of these things forward at the same time. And so we have a few clinical trials happening right now for kids with Pandas. We have an imaging trial, an MRI trial right now where we are trying to look at brain imaging sequences with MRI to see if they help us in the diagnosis of PANS and Pandas. And then we have a trial actually for an imaging trial for adults. There's no treatment as part of it, but it is looking at, it's a different type of imaging called a PET scan that we can do in adults, which we can't do in kids. And we are looking at non-Pandas, but kind of typical, whatever we want to call the non-Pandas, variety of OCD. We're looking to see if there are increases in inflammatory signals in the brain in adults with OCD. So we're trying to sort of come at this from a few different angles right now. That's, I think, that's the majority of what the past 5 years have been for our group. And I'm sure we'll have plenty of time to talk about this as we go on too. But and now we're just trying to sort of see how much we need to change what we're doing in the face of COVID as far as treatment and diagnosis and things like that versus some of the lessons we've learned from treating, do they still apply to kids who have sort of exacerbations or the onset after COVID?
That's fascinating, Colin. We actually had a few advanced questions about kids with Pandas versus adults with seeming symptoms or adults who've recovered. So we'll be coming back to that a little bit later in the broadcast. Okay, terrific. So I'd like to introduce Dr. Amy Young. Amy is the founder and director of the CBT Center for Anxiety and OCD and has been working in the behavioral health field since 1995. Dr. Young is a licensed clinical psychologist specializing in treating generalized anxiety disorder, social anxiety, panic, separation anxiety, PTSD, OCD, and specific phobias. We're really excited to have Amy with us tonight. So we have an additional level of care and some conversation around CBT as well as ERP. Amy, would you like to tell me a little bit about what you have going on?
Sure. Thank you so much for having me. I was excited to be meeting tonight and talk more about this topic that's near and dear to my heart. So I'm a licensed psychologist. I own a group practice, CBT Center for Anxiety and OCD. We are a CBT program that specializes in the treatment of all things anxiety, OCD, OC-related conditions, tics, BFRBs, PANS, PANDAS, you name it. Subspecializing in ERP, CBT, all the things that are good for PANS and PANDAS. We've run a parent support group for PANS and PANDAS. We have a staff of about 35 clinicians who I work very diligently to train on treating the clinical psychology side of PANS and PANDAS and offering parent support in a situation that can seem really overwhelming and cumbersome.
I think you might be the first person that's ever said I've trained 35 clinicians on PANS Pandas. That's actually quite a statement. And so I thank you for that. And I'm so glad that you've raised that forward. Okay, so full disclosure, in addition to being the president of the International OCD Foundation's board and executive director of the Pandas Physician Network, I come to this from a personal standpoint because I have a daughter who was diagnosed with Pandas when she was 7 years old. She was a very classic onset. She's now 20 years old. So we've walked a long way through this journey together. And I've gotten to know a lot of people in the field as we've all raised money for research and trying to figure it all out. So I bring that parent perspective. And if anyone has particular questions from that perspective, I think both Amy and I are happy to jump in on that side. I probably will vary between saying first names and the more formal doctor. Everyone here is a doctor, and so I will try to keep it that more very formal basis. But just to give you guys some heads up on that, I tend to get a little more informal. So I had a basic question, which is just what is Pandas? And so I thought we might just start with that because we've lots of people in the community who come here for OCD talks and may not be familiar with what PANS and PANDAS are. So if I could ask Amy to kick us off with just a brief description of what we're talking about.
Sure. So PANS and PANDAS is conceptualized as an autoimmune encephalitis, oftentimes with sudden onset, seen with a whole host of symptoms, including OCD, tics, rage, movement issues, sensory issues, hallucination, just changes in personality that are really characteristically different from the way that the child presented previously.
Okay, terrific. And I'm going to say what PANDAS stands for. I always think is like one of my favorite spiels. So PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep. And we'll put that up there too. So Kyle, could you talk to us a little bit about how PANDAS originally started to be defined and then how that morphed into PANS and why we say PANS Pandas?
Yeah. So PANDAS grows out of a disorder that was around for a long time called Sydenham's chorea. So there are a number of autoimmune conditions that can happen to people after they have a strep throat infection or a different kind of, a strep infection somewhere else in the body. Strep is, for reasons that are still being worked out, strep is very able to generate an autoimmune process in some people who probably have some genetic susceptibility to developing autoimmunity after a strep infection, but that is theorized and unknown, not something we can test for right now. So this disorder called Sydenham's chorea was first characterized in the late 1700s, and it's a movement disorder. So kids would get strep throat, they would recover from strep throat, and then they would develop this really kind of writhing characteristic movement disorder that actually had a high rate of some really odd behaviors as well. So, you'd have the movements, then the character and kind of the nature of the kid would be different as well. And what has become appreciated in the last 50 years is that Sydenham's chorea starts with a movement disorder, but a lot of the kids also have new onset behavioral and psychiatric disorders too, and prevalent among that, and not exclusively, but prevalent, is obsessive compulsive disorder. So that was the beginning of the link between a strep infection, strep throat, and then sort of the development of obsessive compulsive disorder and through kind of autoimmunity. And Sue Sweeto and Judy Rappaport at the National Institute of Health in the 80s and 90s were looking at different ways people can develop obsessive compulsive disorder and different ways kids can develop obsessive compulsive disorder. They decided to look at Sydenham's chorea as a way to learn more about OCD. And then they found a bunch of people that were having new onset OCD after a strep infection, but they did not look like Sydenham's chorea. They didn't have the same movement disorder. And so they coined kind of, first it was called PPNs, then it became Pandas, pediatric autoimmune neuropsychiatric disorder associated with strep. And so the idea, again, is that you have a strep infection, the infection does not get into the brain. So it's not an actual infection of your brain tissue. And the infection doesn't really need to disseminate even beyond your throat. And then most of the time that we see people have the onset of the symptoms, the strep infection has gone away. It's been treated. That's not always the case, but it's frequently the case. And so again, the idea is that there is this induced autoimmune disorder from the infection. And then those immune cells that were activated as part of fighting off the strep infection, then, they somehow are able to disrupt the normal workings of an area of the brain that we think is involved in generating obsessive compulsive symptoms.
So one of the questions that I get a lot from folks is that if my child has strep, has that caused their OCD? Is that 100%?
It is a really hard question to answer because we try to stick to, so I think where this falls down the most, and this has been consistent for, I think, 10, 20 years, is applying these diagnostic sort of guidelines to the actual disorder itself. Because we don't have a blood test that we can do that says, I think that really reliably discriminates kids who have obsessive compulsive disorder from kids who have PANS and Pandas, right? We don't have a blood test for that. We don't have an imaging kind of biomarker for that. And so one of the arguments against Pandas being kind of a real thing has always been that these were kids who were bound to get obsessive compulsive disorder and they just happened to get a strep infection. And so that's still a hard thing, I think, to separate out. But the reason I think it matters is this idea that if the obsessive compulsive symptoms are due to more of either an autoimmune or an inflammatory nature, can we treat those kids with a different kind of set of therapies and, do a better job, sort of be more efficient or be more kind of responsive to the cause of their symptoms?
Okay, terrific. And Dr. Rice, can OCD be caused by things other than strep or infectious illnesses?
So that's a really interesting question. So what's genetics and what's a difference in your brain or a reaction to an infection? For many years, there's been an interest in the relationship with all kinds of mental illness, including schizophrenia and other kinds of concerns related to infections. So this is something we're still honestly trying to figure out, there's so much work still left to be done here. On the other hand, we do know that OCD tends to run in families. So is there a genetic propensity to have it? And so I guess the answer is that we're trying to figure it out.
Susan, you're on mute right now. Sorry.
Oh, that's funny. I swear I would never do that during this live feed. Thank you, Kyle. So let me ask you, Dr. Rice, if we don't entirely know what's causing it, if a parent has, and generally what happens with Pandas and PANS generally, we have an acute sudden onset, right? So we have a child who seemed like they were doing pretty well. They might have mild anxiety or other childhood normal behaviors, but suddenly overnight they become a different child and have severe either eating issues or OCD. When you have that sort of situation, what do you suggest, Dr. Rice, as a first step for that family to do?
So I would go and look for the infection, identify, is the child sick? And so I would be in your pediatrician's office the next day and looking, because it might not be strep. There can be all kinds of other viral infections that could cause this. And pediatricians are quite good at that stuff. And they can tell you, oh my goodness, this looks like Coxsackie virus. This looks like, they can tell you usually what is the most likely type of infection. If they can identify an infection, then the next step is to treat it. If it's possible to treat the infection. So if it's strep, treat the strep. If it's a viral infection, that gets a little harder. And then the next step is to talk about anti-inflammatories. That's one of the reasons why we're in Arizona. Our whole crew, have gone out both in person and across the state, in person across the state and virtually, to talk to small pediatric practices and larger pediatric practices to share what pediatricians can do immediately, so that there is, and I will say that the pediatricians who we have connected with have been very, very receptive. They're so grateful. I saw something in here, my pediatrician was no help. I honestly think that that's because they just don't know. And this is generally not taught in medical school. And so they're on their own trying to learn this. So once we have reached out to them, I get phone calls and emails and all kinds of connections with doctors across the state all the time. And they're very grateful for the information, and they're very willing to do the next steps. So, but honestly, I do really think that it's just that they're not sure what to do. And there's been a lot of pushback in the medical community, as probably everyone here on this call knows, that this doesn't exist and that there's quackery and all these sorts of things. And doctors feel uncomfortable with that. So usually what they'll do is just do nothing. And that's not what we want them to do. So I truly have found that empowering what I call the boots on the ground people. We've also give presentations to school nurses, to emergency department physicians, to anybody who would be sort of the first line seeing children.
Okay, terrific. And I'll ask we have an amazing team in the background that's taking care of answers to some of the questions in the chat. And I'll ask if you guys could put up the Pandas Physician Network. There you go. There's a flow chart that we're putting up, which is often helpful to doctors who do not have someone like Dr. Rice in their state to reach out to. That really helps them understand what most scientifically proven ways of diagnosing and treating onset of Pandas and PANS. So I hope that's helpful to you. Dr. Young, I'm wondering if you could touch on, let's say we've had a family that's been struggling with this for a little while. When they come into your office, what makes you think Pandas, PANS versus fairly traditional childhood OCD?
Sure. Yeah, so I mean, for sure, the sudden onset is one of the things that, will trigger some questions about PANS and PANDAS. Anything that is uncharacteristic of the child, they were fine one day, they weren't fine the next. I can remember the day. Just the sense of overwhelm and frustration, from the parents. Interestingly enough, sometimes things like even asking questions, has your child tried to jump out of a moving car? Like things like that I've learned, through just anecdotal, experience. And sometimes parents will think you're a mind reader. It's just you've seen things over and over again. So I think one of the other questions then too becomes questions about a more insidious and slow, onset when you track it back and you see a long history of infection, specifically, say, strep. I think it brings up a lot of questions as to whether that might have been something that was happening, all along, and really walking that fine line between not wanting to send parents on an unnecessary wild goose chase and want to be able to provide effective treatment. But certainly if you see that sudden onset, a dramatic change in behavior, something that was very uncharacteristic. And I also wanted to piggyback on what Dr. Rice was saying in terms of the first steps in talking with your pediatrician and looking at that great, flow chart, how much of an advocate parents have to be with this. So many people do their own research and find out about PANS and PANDAS on their own. I would say the greater preponderance of parents have found that on their own, as opposed to a physician presenting them with that idea, and having them feel heard and understood and supported, and really acknowledging, the grief and trauma that they have gone through as well, and just encouraging them to trust their gut and to bring in information to their pediatrician, their physician, educate them, teach them, show them this information, show them all the valuable websites. So I strongly encourage parents to be advocates and trust their instincts about their child.
Okay, terrific. We had a question at 7:21 from Krista Gray about whether IVIG is still the gold standard treatment. She asks, particularly after other options have been ineffective. And I would ask the panelists also, what is the first treatment, and then is IVIG still the gold treatment? Maybe Dr. Rice, if you want to start with that one.
Sure. So we do a tiered treatment, as in the flow. We look at different anti-inflammatories. We'll treat the infection. We will use non-steroidal anti-inflammatories. We'll use prednisone, sometimes IV steroids. And then for children who are not responding, we do get to IVIG. Our center does not do plasmapheresis. I know that, and one of the reasons is the studies have really looked at they're similar, as far as that one is not really better than the other. And our biggest concern is that for plasmapheresis, you need to put in very large lines, and that can be dangerous, particularly with a child with OCD not being able to tolerate that. And so we've had some unpleasant experiences with children pulling out lines. So it's just kind of dangerous. So other places do it. We don't do plasmapheresis.
Okay, terrific.
Maybe actually, could we just step back also and just say that IVIG and plasma exchange are, the idea behind them is that there's an autoimmune antibody. There's an autoimmune process that is happening there. And they are two treatments that are mainstays for treating autoimmune conditions in kids and adults. And the idea then with PANS and PANDAS is that, again, do we do a better job treating with these anti-inflammatory autoimmune treatments than we do with other gold standard treatments for OCD? I'm just sort of trying to match the correct treatment. IVIG is you're getting blood products from other people that are pooled together. You're getting antibodies. So IVIG stands for intravenous immunoglobulin. And then plasma exchange is actually you are removing the antibody component from someone and then allowing them to sort of repopulate their own antibodies, kind of not from scratch, but sort of you remove the good with the bad in plasmapheresis, and then it's sort of built up from a more kind of basic state.
So do many of your patients, Dr. Williams, do well with treatment just based on anti-inflammatories and antibiotics, or does everyone move to IVIG? Can you talk a little bit?
So I think for multiple reasons, it is you shouldn't think about IVIG unless it's, I would say, a life-threatening kind of situation. If you haven't tried anti-inflammatories and antibiotics, and I think when we talk about these two, we should say it doesn't mean that it's open-ended kind of antibiotics forever or anti-inflammatories forever, because we can certainly get into those medications and treatments causing their own problems if they are used to, depending on the dosing and the chronicity. And so exactly like what Dr. Rice was saying, I think the best way to do it is stepped therapy, where you've tried various things, and then I think too, and Amy can speak, Dr. Young can speak to this, but we always talk about cognitive behavioral therapy for the families, for the kids, because, and I think people have said before, why, if this is an inflammatory brain disease, like why do you think that CBT would be helpful? And I guess the only thing I can say in response or think about is like, well, for other types of OCD, we think it's a genetic, your brain sort of is structured differently, and yet CBT still works there. And we still see that CBT is helpful for just adjusting and building tools and strengthening things while hopefully, a different kind of healing process is going on. So we always we always talk about that with our patients as well.
So let me go in two
can
directions on that. Let me start with you, Dr. Rice, because I see you wanted to jump in on that anti-inflammatory, and then I'll go to CBT ERP next.
So I will say that just to concur with what Dr. Williams said is that we really strongly suggest and require that our families are doing a behavioral intervention like CBT, ERP. And in our clinic experience, getting to IVIG, we've probably seen close to 2,000 children, and we only about 10% are getting to the IVIG. Everybody else we're treating with oral anti-inflammatories.
Okay, terrific. And we had a question before I move over to sort of the CBT side. We had a question at 724. Can you elaborate on anti-inflammatories? Are we talking NSAIDs, steroids, antihistamines, turmeric supplements? So if I could get you guys to comment on that for a second, and then we'll turn to CBT.
Yeah, we use non-steroidal anti-inflammatories, and at times we use steroids, and particularly oral steroids. Steroids can have a ton of unwanted, unintended side effects. So I think there's a higher threshold to move to steroids, and then we have tried. I don't prescribe turmeric. I don't think it does any. It's not going to harm anything or do any damage. I just don't know. We haven't sort of used it as kind of the first or the only therapy, so it's hard for us to judge the benefit that comes from it. But I don't think it does anything bad. And those are kind of the mainstays for us. Naproxen, more than ibuprofen, not because it necessarily works better, but because naproxen only has to be dosed twice a day, whereas ibuprofen really, to get to the dosing that we try to hit, is 3 times a day, which I think is really hard for anybody to keep up with, right? Parents or adults.
Okay, terrific. That's very helpful. So the IOCDF popped up a description of what CBT is. We throw out all kinds of shortcuts because we get tired of saying the words over and over. So that's really all it is. CBT is cognitive behavioral therapy. And there's a specific subtype of that, which is called ERP, which is a couple different ways of saying it. I generally say exposure and ritual prevention. And that's a very specific type of therapy that has been studied deeply in terms of OCD. And what I always like to say to families that I work with or kids that I'm talking to, that, if you were in a car wreck and you broke your leg, the first thing that we would want to do is to repair the injury, right? We'd put you in a cast. But the second thing we might do is some physical therapy to ensure that you can really use your arm and you regain that strength again, right? We wouldn't just do the cast and then say, hey, good luck. I think of ERP like the cast, like the physical therapy rather. So we're going to work on the cast, which is all of the treatments that we might do medically, but now we're really going to get your brain back into good shape because it may have learned some habits along the way. And so, Amy, I wonder if you could talk to us a little bit about ERP and how that works for children.
Sure. Yeah. So CBT is, as Susan said, stands for cognitive behavioral therapy, and it really encompasses a number of different kinds of interventions and strategies. One that we use primarily and is the gold standard for OCD behavior symptoms is ERP, sometimes called exposure and response prevention, sometimes exposure and ritual prevention. Both are correct. And essentially, what we're doing with that is we're doing 2 things. One is exposure, graded, repeated, and prolonged exposure to situations that are triggering, that are anxiety provoking, paired with, and this is a very important piece, paired with ritual prevention. And so that's not doing the things that we would normally do to relieve the anxiety, whether they are overt physical things that we do or whether they're covert things like mental compulsions, rumination, mental analysis, which are also really important to ascertain and to treat. Part of the premise in cognitive behavioral therapy, and this is true for ERP and other things we use for PANS and PANDAS, is that because of neuroplasticity, because of the brain's ability to change and alter synaptic connections, that we are in fact healing the brain. We are in fact treating the brain and a lot of the essential brain damage, that's happened as a result of PANS and PANDAS and autoimmune and attacking our brain. And so we're learning a new response through various ideas. One is a habituation model, an emotional processing model that we get accustomed to the exposures, and another is an inhibitory learning model where we're learning new things and thereby learning a new response to a trigger. So very much we are changing the way that the brain functions. And, many forms of research have shown us that cognitive behavioral therapy is exceptional at creating longer term change because we're learning a new response to a trigger. And I also like to think that the things that kids are learning in CBT and specifically ERP not only will help them with some of the symptoms of PANS and PANDAS, but some of the other things that come along in life because we're really looking at approaching these things in a very different way, moving toward things that are difficult instead of away from them.
Our entire family are ERP practitioners. Whenever we notice something is frightening us, say speaking in front of this many people with this many really terrific doctors in front of me, right? And the answer is that we do it anyway.
That's right. That's right. We live the exposure lifestyle.
That's right. We live an exposure lifestyle in our family, and that's taken us a long time to do. I think a lot of people are sort of scared to start ERP with kids. It does not have to be scary. You're not going to have to do the biggest thing first. Parents and kids, we're not going to start with the biggest. Just like we do in math, we like to teach addition before we teach calculus. So we're going to do addition first, which might be addressing the tiniest, smallest thing that's impacting the family. And there's really, I see a few questions about whether you should do anti-inflammatories first and then do ERP. As far as I'm concerned, once the brain has turned towards OCD, I like to do ERP. I like to recommend that to all my families. I think it's a great lifestyle, even if you only take 5 therapy sessions on it and really kind of learn what it looks like and how to do it, and then you begin to practice it at home. I consider it to be very preventative for OCD, and that is our ERP lifestyle that we really live. So I encourage it. It is not nearly as scary as people think it is. People think therapy is terrifying. You're going to have to do the biggest thing you're scared of. I assure you that it is not. So I encourage you to look into that if this is something that's going on with your family. Sometimes I have folks that tell me that their doctor who is treating Pandas or PANS says that they don't need ERP therapy. So all of us here, all of the researchers and the treating doctors, all of the organizations that are supporting this town hall are here to say that both things are valid things to do. They're valid to do at the same time. We do occasionally have a child that's too ill to initially to do ERP, and that's certainly understandable, but it is something that we encourage for everyone. Dual treatment, we want your kids to be happy. That's really where we're aiming for here. I'm going to go back a little bit and talk about some other triggers. Let's see, we've had a number of questions about allergies. And so let me just pull up one of those. Let's see. I've got a question sorry, I lost it. 1 second. I've got a question at 7:24. Would you address the role of food allergies, if any, and whether you think stool tests for food allergies are reliable or valid? Do I have anyone on the call that would be willing to take that question? Dr. Rice?
I guess we don't have a GI or an immunologist on this. So my kind of clinical partner in our clinic, who I work with every single week, gets this question all the time. So I'm just going to tell you what I hear is shared. We look for, we do screening labs in our clinic, and we look for celiac. We also look for inflammation. And so, and I would say that a couple times a year in the last few years, we've identified children with celiac disease, and then we move them on and move them towards that treatment. Food allergies per se as causing PANS PANDAS, we have not seen. However, when children have sensitivity, we do the testing to see if that can make them feel better overall, but not really as a cure for the condition.
Okay, terrific. And we have sort of the same range of questions From Shelly at 724, my daughter's allergic to cats and dogs. Can allergic reactions in the environment cause inflammation in the brain that leads to OCD? And I'll ask Dr. Williams to tackle that one.
I don't know. And I think part of the reason, so I think I would be, I would have a high bar for thinking that the allergies were causing something with this, if it was an environmental allergy and not a sort of an anaphylactic allergy to like shellfish or something like that. But I think, what this does is highlight something that is actually very difficult for us, because so we talk about inflammation. We talk about, a lot of the literature around PANS and PANDAS is based on brain inflammation, basal ganglia encephalitis, autoimmune encephalitis, these kind of things. We actually have an incredibly hard time imaging or assessing inflammation in the brain of someone in real time. So for adults, there are some scans that can look at the activation of immune cells in the brain, but those haven't yet sort of percolated into clinical care. They're still, from what I know, they're still a research tool. And in kids, we have a really hard time. I mean, we aside from doing a spinal tap, which we usually don't do, it is incredibly hard for us to say, yes, your OCD is due to inflammation. So when we are kind of curious about what things could drive inflammation, it's a hard question to answer, because the output, sort of like us assessing inflammation, is so difficult. I think that it's hard to know what can cause it and what can't. And the same is, I think, true for knowing if IVIG or if anti-inflammatories actually decrease that inflammation in a way that correlates with, a decrease in OCD symptoms. There's some evidence for that, but I think there's a lot still left to be understood about that response.
So I'll tack onto that at 743. Jackie asked, I've heard that histamine levels can trigger, so taking antihistamines can help. Dr. Rice, could you talk briefly about the role of antihistamines, if there is one?
We don't use them regularly, but if someone has very significant allergies, in addition to everything that's going on, as Dr. Williams was saying, it's yes, allergies are inflammatory. We don't know. We don't know. We don't know a lot. So generally, if children have allergies of any kind, we treat them and try to at least get that piece of the concern off the table.
Okay. Yeah, thank you. Dr. Young, I have a question at 738 from Julie. Is CBT ERP as effective when symptoms are mostly obsessions without the compulsions?
Sure. So this is a great question. There are most likely compulsions, going on, even if we don't see the compulsions. So sometimes there are subtle compulsions. A compulsion is anything that we do to try to relieve the anxiety. And again, there can be a difference between an overt compulsion, a checking, a fixing compulsion, a hand washing compulsion, and a covert compulsion like rumination, mental analysis, figuring things out, counting. There are many things that can happen in our head. There can also be subtle compulsions like reassurance seeking that you'll see a lot with kids, or telling compulsions, or confessing compulsions. So the vast majority of the time, there are compulsions that occur with obsessions. It just may take a little detective work and a little digging, and certainly working with somebody who's an OCD specialist can probably catch them pretty quickly. And so either way, CBT can be effective. Again, it's best if we're doing exposures to the particular triggers as well as ritual prevention. But I would say most of the time there are compulsions. We just have to, sort of ask the right questions.
I noticed when my daughter was young, she used to say how much she loved me all the time. I got a lot of I love yous.
I love yous.
A lot of I love yous. I really felt like I was probably the best mom in the entire world. My child loved me so much.
Right.
And I would never have guessed that was actually a compulsion to a number of things that were happening in the environment that she was pretty sure if I touched X that had been touched by X earlier, I would die or she would die. And so there were all kinds of interesting compulsions that I wasn't able to see at first. So
Yeah.
it didn't work, but
And they-
once we identified them, we figured it out.
Yeah, a lot of them too can be very egosyntonic. They're not necessarily compulsions that are problematic. I mean, if our child is telling us that, that they love us, or maybe they're engaging in prayers or trying to get things just right, that might be something that we like, and not necessarily know that it's a compulsion until it occurs repeatedly over and over again, maybe to the point of annoyance, and you begin to see the connection. And it's hard if you have a child who is not quite as verbal, a younger child, to be able to articulate, what's happening. And there may be a lot of compulsions, obsessions and compulsions that, have happened for some time without the child or the parent identifying them as such.
It's so funny to hear you say it might become annoying. I can remember talking on the phone to a friend about something fairly serious, and my daughter coming up to me a number of times saying, I love you. And I was like, what's happening here? Like, this is unnecessary and odd behavior. And so then we were able to figure out that was actually a compulsion, and she was unhappy, I was unhappy, and dealing with it was really very helpful. All right, I see a question here that goes back a little bit to diagnosis and treatment, but less about the child that just got sick a month or 3 months ago and more about what happened a while ago. So I have a question from Mandy Hunt, and I see a number of folks with a very similar question at 736. If a child's OCD was caused by Pandas years ago, is there any benefit now in finding out? Is it possible to find out? Surely the Pandas issue is long past being treatable, and then you can only use standard CBT ERP, and that is a question. So I'll pass that to the group and ask who would like to respond.
I can jump in on that if we can, because I think it is incredibly hard to tell who has PANS or Pandas when we are a few years out. I think it's hard. So could you look back in someone's history and say they met all the criteria from PANS and Pandas? Absolutely. Are they going to respond to the therapies in the same way? I have no idea. We really don't know if that's the case or not. So I think there are times when people feel like they've been either misdiagnosed or, and I think that right now it's really hard to say diagnosis versus misdiagnosis if we don't actually have reliable sort of blood markers, biomarkers, and I think we will get there, right? I mean, this is not to say that it's giving up, but right now it's sort of, we have a lot of questions about what should I do based on if I've had OCD for 5 years and I had strep infections. 90% of school-age kids will have a strep infection at some point, right? So that we know that if it was simply sort of saying strep plus OCD, we would probably catch up a bunch of people who have OCD for other reasons other than kind of PANS or Pandas. And kind of in that same vein, we have a lot of, OCD is 2 to 3% of the population, right? Pediatric and adult populations. So it's actually quite common from what we would call, and we don't know how common PANS and Pandas is as a subset of that. So we have a lot of people who have had OCD for a while who come in with lab work saying, my strep titers are higher than normal, or my mycoplasma titers are higher than normal. Does this mean that I have strep? Or I'm sorry, does this mean I have PANS or Pandas? And it's really hard to tell because we have a lot of people who have kind of lab values that are just slightly elevated, and it's hard to know if that's actually associated or not associated. So my kind of 2 cents for folks is to, I think, be open to various forms of treatment. And for me, that also, it's not the first thing I do, but it's something I consider as well as using SSRIs for kids too. There's a lot of, I think, information or strong feelings on SSRIs being bad for kids who have PANS and Pandas. And after thousands of kids, I don't find that to be true. It's not the first thing I do. So I'm not saying that we should start an SSRI in everyone. But if people have gone through multiple different rounds of therapy and they haven't tried it and they feel like they shouldn't because they have PANS or Pandas, a lot of times you find out that, that kids respond well to it. It's something to keep in mind. I'll stop talking now, but I also too I saw from Paul Ryan on here that said we should definitely talk about the IVIG trial before the end of this and just kind of how this fits into everything. But I'll kind of take a step back on the treatment and everybody else can jump in.
I think one of the things I often say to parents is if it was a while ago and the child's doing pretty well, certainly doing ERP is the first thing that should be on the list. But if your child falls off a cliff and goes from having like a 2 on a scale of 1 to 10 of OCD to an 8 or a 9, literally within a couple of days, you should head to your pediatrician and test for infection. Mm-hmm. So that's kind of one of the things, if you suspect Pandas in the past, you can't quite figure out what to do about it now. It's that cliff moment, okay? So when you feel like your child just jumped off a cliff, then head into the pediatrician, check for infection. I find with my daughter that she often feels it behaviorally in what her brain is saying to her before she knows that she is sick. And so if we get into the doctor right away, she will frequently have an ear infection or strep, and we're able to treat that even though her first sign was not the raw red throat. Her first sign was what was happening here. Okay, we've had a couple different questions, and then we'll turn back to Paul's question about the IVIG trial. I think we have until 8:30, so we've got we have a question from Max at 7:27, which really ties into that whole question of onset in the past and then onset now. He asks, have any of you treated or worked with a case of adult over 40 onset of autoimmune neuropsychiatric syndrome with no prior history of OCD? So I'm assuming a sudden onset of OCD at that over 40 age. Has anyone worked with that age or have any comment about that?
I have worked with adults with OCD, and I think it's important to. I mean, I've worked with adults with sudden onset OCD for a few different kind of reasons. We think, right? So there are some people who have a stroke and then develop OCD after that. I don't think that that's what this person's talking about over 40. But there are multiple different ways to develop obsessive compulsive disorder that, again, may be inflammatory or autoimmune, or may have something else as well. There's Susan and I are on a task force for postpartum obsessive compulsive disorder, and that's a common onset. There are forms of even post-traumatic, kind of post-trauma obsessive compulsive disorder too. So I think with this question here for the, do we think about this being possible in adults? I don't know that there's anything that I would say is impossible. It's just incredibly hard to test, right? So if I saw a 40-year-old with this, it would be hard for us to determine that it's actually autoimmune in nature because, again, those tests for the brain kind of antibodies are still, I think, in the sort of their infancy in some ways of trying to know how specific they are for autoimmunity.
And I'll put a plug in for the research side for those of you that are interested in doing fundraisers, lemonade stands, et cetera, to raise money for research. Really trying to fund those tests for kids is then something that we might be able to take to adult populations and begin to do studies there. So the answer is we don't know. Because there hasn't been a lot of research in that area, but that we're certainly, all of us are very interested in what's happening in a number of different stages. Kyle just mentioned postpartum OCD, which is OCD that begins during pregnancy or becomes very acute right after pregnancy. And so the IOCDF, the International OCD Foundation, is doing a lot of work in that arena as well. And we've had a couple of town halls on that, and we'll continue to have town halls in that area.
And just quickly, I should say too that there is a whole area of research that is looking at the activation of immune cells in adults with OCD in their brain. So there's another kind of story to this whole thing where maybe there are people that don't meet the criteria for PANS and PANDAS, but they have some type of immune kind of mediated symptoms for their OCD in adulthood. And I think time will tell sort of with that because I think we all, understandably, we put a lot of emphasis on people meeting criteria for PANS and PANDAS, but the other question about just can we identify people who would improve or benefit from immune therapies, whatever their diagnosis is that's kind of, I think, this thing that overlays everything that we're looking at, and that could be in adulthood or it could be in childhood.
was also thinking about a case, correct me, it's been a while, but a frontotemporal lobe dementia. That's
Yeah.
another one that I've seen with a sudden onset in adults.
Yep. Yeah. Actually, so Carol Matthews does
Okay.
a lot of it. Is a researcher at I think University of Florida now. Has done a ton of work on these types of neurodegenerative, particularly frontotemporal dementia
Yep.
and hoarding or other types of OCD onset that are pretty severe.
Okay, great. I have a question for Dr. Rice from Lisa in Madison, Wisconsin at 729 about the gut microbiome. How does the GI microbiome impact or contribute to Pandas and PANS? Is there testing and treatment that can improve Pandas and PANS symptoms? And is GI map or other testing helpful in guiding this treatment? If you want to address a few of those questions as you're able.
Sure. I can tell you what we've learned, and I don't think I can answer all of your questions yet. What we have been doing is looking at twins who have pandas and where they're discordant, meaning one twin has it and the other twin does not, and then comparing their microbiome. And what we have found is some very striking differences between the microbiome of the child or some teenagers who has the condition and the control twin, the twin who does not. And the most striking thing that we're finding is that the microbiome in the twin who has PANS is restricted, much less variety of bacteria. And there are a couple of bacteria that are more prominent and in the typical twin. And so we're looking at that to look at, could that be a possible treatment? Could we give them the particular bacteria that they're missing and see if that would help? So we're very early in this, and but basically restricted by microbiome. Now, could you do it yourself? I'm not sure. The way that is done in the lab is so intensive. I mean, we look at every billions of gut bacteria and are able to map them out. I'm not sure that you'd be able to do that without participating in a research study.
I'm really excited that you're doing work with twins. I think that answers a lot of the questions that we have in the field. All right, I'm going to ask one more question about medications because I've seen a couple of folks ask this. At 7:30, we have a question: what has the research found about the use of rituximab? Kyle, Dr. Williams?
Yeah, I'm trying to think now of what papers have been published with rituximab. So rituximab is a treatment that so similar to the other treatments where we're talking about an anti-autoimmune treatment. Rituximab is actually a treatment that destroys the cells that produce antibodies. And so if you have cells that are producing autoimmune antibodies, then you can use this treatment and it will, in theory, destroy some or all of those. Probably not permanently, but it also destroys the beneficial antibodies that you make as well. So it leaves you immune compromised for a time. It's used as a chemotherapy agent. It's used in some other types of severe autoimmune conditions. And it has been used in Pandas, and I know that Beth Latimer has published some case series on it. We don't use it. I really feel like it can be used safely, So actually, I'm probably not really the one to speak about it because I've never used it. It seems like there's the potential for things to go wrong with rituximab, but maybe that's my bias with it. I think it is going to take more study, but if there's other ways to sort of solve the problem, then I think it's important to explore those as well, because the potential kind of secondary side effects for rituximab can be pretty significant.
Dr. Rice?
Similarly, we don't use it, and similarly, we're concerned about we're making someone immunocompromised. And frequently what is done with rituximab, and we in our clinic sometimes are treating other conditions that require rituximab. So not for pandas. Those children become immunocompromised, and sometimes what they then get is IVIG as a rescue. So you're doing both rituximab and IVIG, but yeah, it wipes out your B cells so that your a whole entire immune cell line. So I know that, yeah, some people are using it. We don't.
Can I just jump into, like, one of the things that comes up for me as we're talking about this and some of the treatment options as a psychologist, it brings up some questions about quality of life and, how many treatments we can engage in and the cost and the extent to which we have to go. And I've had families moving to different states, moving with the child who has PANS and PANDAS and getting an apartment, living in a different part of the country away from their family. Haven't even talked about the trauma, that families experience, and a lot of post-traumatic stress symptoms. Is, as a psychologist, the other piece I want to, mention in here is really considering quality of life issues when we're making decisions about these kinds of things. And, I've worked with families where they can spend, years of their life trying to track this down and provide, appropriate treatment. And I think, again, the psychological, piece I'd like to add is I think we do have to sometimes sort of stop and ask, in what way are we enhancing quality of life? And, how can we also consider that as we're trying to treat a really sick child?
I'm curious, just to follow up on that, because I do think it's a really important question. I know some of the parents feel like their children have lost so much quality of life and are trying to regain that, and they are often willing to go anywhere, do anything, because it does have such a huge impact on the family. And so I'm just curious about if you have a child who will not participate in exposure and ritual prevention, ERP or CBT, how do you begin that process of trying to give parents a way into the illness to function a little bit more on a day-to-day basis?
Sure. So, we do everything that we possibly can to engage with a child and create a therapeutic alliance, whether it was pre-COVID, say going to somebody's home. I've met with kids in the car, kids with PANS and PANDAS, kids without, PANS and PANDAS, met, them in the car several times, as we do graded exposure, even in, in the way that we, provide CBT and ERP, and slowly making their way, perhaps into the office. A child's work is through play. So having the treatment be fun, using all kinds of developmentally appropriate tools to engage the child. So certainly doing everything we can to develop a working alliance, like with the child. And then if we're just really not able to do that, then we'll use more of a parent coaching, parent treatment model. There's a model called the SPACE model, which exclusively provides cognitive behavioral therapy to families, to parents, and really teaching them about how to implement ERP and other CBT strategies to the child in lieu of being able to have the child participate.
And I wonder if the IOCDF could put up the link for the SPACE program. I think that would be really great so that parents can see what that is. At the International OCD Foundation, we do a lot of courses for parents on family accommodation and how to begin to do some treatment even before the child is perhaps willing or able to do treatment. And that can be very effective as well. We run a number of online kids camps. We do all sorts of online programming around family accommodation. So that's probably the key word that you want to look into is family accommodation. And as a parent, I just want to say to you, that does not mean that you're doing anything wrong in the least. When we say accommodation, sometimes people are like, oh, what am I doing wrong? It just means really learning how you may naturally have become involved in the child's OCD and what things you might be able to do to slowly shift that to help the child learn that they can have the strength to move into ERP therapy. So family accommodation is your trick there. All right, so at 7:43, we had a question from Paul Ryan, and I'm going to ask you to pop that up. Paul asked essentially if the physicians here could talk a little bit about the upcoming IVIG trial or the new national IVIG trial and how that might help in validating the treatment towards the scientific community. I'll start with Dr. Rice since I believe that's happening in Arizona.
It's happening all across the country. So, so one of the issues that comes up with trying to get IVIG approved, if the team feels that it's appropriate, is that there's not a ton of research to show that it works. And so there's a company called Octapharma that's doing an international trial, both in Europe and the United States. We are looking for children who have had new onset of symptoms within the last 6 months, and they meet full criteria. So you would go through a full evaluation at a site, and they meet full criteria, and they're allowed to try other things first. So it's not like we go straight to IVIG. And then it is a placebo-controlled trial. So the child could initially get IVIG or normal saline, so water, salted water, and then, but it's called a crossover trial. So they would get one, and then a few weeks later they would get the other. So you would be guaranteed to get IVIG in the trial, and then there are weekly to every other week psychometric evaluations and blood testing that happens throughout the trial. So it's an intense commitment, but every child who participates in it gets IVIG.
Okay, terrific. And what are we hoping to accomplish through this trial in regards to the scientific community and the validity of Pandas and PAMs?
This is hopefully to show the research world that we can make a difference with IVIG. So the psychometric testing that's done is quite intensive. And so, and there was a lot of work done to make sure that we were choosing the right tools to be able to follow. And so we're hoping to convince people.
Well, and I think I mean, I'm sure a lot of people know this already on this call, but IVIG is incredibly expensive. It's not, so it's to pay for it out of pocket is out of the realm of possibility for most folks. And so we're requiring our insurance companies to handle the cost of this. And by and large, the insurance companies have said that the level of evidence is not sufficient for them to actually take on the cost of paying for it. And that is in part because, some of the trials that have been done previously, one of the trials that was done at NIH showed that there was a great benefit of IVIG. And then the second one that was done at NIH that I was involved in also showed that it actually didn't do as well as we thought it did. And so the answer is potentially then we're trying to find the truth, right? Essentially of how beneficial it is and then who it's helpful for, because we have to select the right sort of people for the trial in order, we think to see the benefit of the treatment. And if it comes out working, then it's more evidence for the insurance companies essentially that this is a needed treatment that we can look for in the future. So it's still, I think it's still an open question that is taking a lot of resources, and thankfully those resources, Arizona has taken the lead in starting this, and now other sites are coming online. So Mass General will be coming online soon. Dartmouth, I think there's Arkansas, UCLA. There are multiple, and there are. So I think you can Google it. You can look for sort of the different sites that are participating. But I think it's starting to roll out now and will be active in the next couple of years in this trial.
Dr. Rice, is there a website that folks can go to see where the different sites are around the country as they continue to come online?
I can get you one.
Okay, terrific. If you put that in the chat, IOCDF will post it for us. Okay, terrific. Thank you. There is so much research happening around OCD, pediatric OCD, and around pandas and pans, around inflammatory, around encephalitis. There's a ton of work that's currently happening in this area. So a lot of encouragement out there that this is being taken very seriously, that really the controversy about whether this exists is now in the past, that there's been so much research to happen from a basic level to show how this is occurring, that I just encourage everyone here to feel free to go to the Pandas Physician Network and read through some of the research, look at some of the very large grants that have been awarded by the International OCD Foundation in the last few years in regards to inflammation and autoimmune disease, and really take comfort from the fact that this is no longer a controversial disease. It is unfortunately a disease that has not yet been fully researched. So there are lots of questions that we still have, but that does not make the disease something that does not exist. So you're welcome here if you have further questions about this.
I guess I was just going to say too that it's been great, and it's been frustrating to be in kind of this space for the last 20 years. Great because I think that it's really moving along now. Frustrating in the sense that it's been a constant challenge, right, to get kind of the people on board for this, for the idea that strep can trigger these things. And then COVID happens, right? And then millions of people are getting COVID at the same time, and which is obviously is horrible. But what happens is that then everybody sort of from the same viewpoint starts to see the things that happen after these infections. And so almost from the beginning, it was not controversial to say, do you think someone can have COVID and develop a neuropsychiatric, sequela afterwards? People said from the beginning, like, yes, we think that that's possible, right? Even when there wasn't evidence for it. And we've been saying the same thing essentially for strep for 2 decades, and the idea has always been like, well, it's maybe, maybe not. So I do think that there is more general acceptance for these kind of associations between infections, and it's just I think more of a matter now of finding the specifics with it.
I will say the first time I heard the word neuropsychiatric COVID said casually in conversation, I sort of looked around me like, okay, did that really just happen? That someone said that an infectious illness could cause neuropsychiatric symptoms? And then it very rapidly became so commonly accepted. And I was like, wow, how did that happen so quickly when in the Pandas and Pans world, we've been working so hard for the last 20, 25 years to have just the concept accepted or to raise money for research. So I'm very glad we're at the point that we are now where funding is starting to happen and we are starting to be able to raise money and people are more aware. And really thank especially all of the parents out there that have gotten so deeply involved and raising money for that research and supporting all of our researchers over the years. So many thanks to all of you out there. Okay, I have a question. I have a couple of questions about kind of counseling and what to do if you have symptoms, you've been treated or haven't been treated, but you have some lingering symptoms. So I'm going to turn this over to Dr. Young. At 7:44, I have a question that I think sums it up pretty well. Wondering what treatments have been effective for children who, for the most part, are well recovered and back to baseline, but continue, for example, with restricted eating and food aversions. Not enough to be debilitating, but enough to be a hardship. And devoid of sound nutrition in this case, not quite back to pre-diagnosis levels. What would you suggest?
Yeah, sure. So, just like exposure therapy works for, germs or, intrusive thoughts, worries, exposure therapy can also work for restrictions with eating. So we would do graded, repeated, and prolonged food trials. With clients, we would do that in concert, most likely with a pediatrician, a dietitian. So it would work much the same way in that we want to create a sense of appetite, a sense of hunger cues, get the stomach and the head, cooperating. And we would go about it in much the same way, creating a graded hierarchy of foods, and just depending on what are the primary needs, whether it's increasing calories or lipids or food selection, increasing repertoire, we would begin with trials of that. Certainly with kids, we might add in some kind of behavior modification or token economy system, some motivational enhancement, making it fun. And we would do that as part of the therapy. So for example, maybe going to some kind of buffet at the local grocery store and getting a plate and trying a number of foods and introducing them. Sometimes what happens is there can be some OCD that gets a little tripped up in that, especially when it comes to things like emetophobia, a fear of throwing up. There might be associations with certain colors, and again, doing graded exposure around that. So we would approach decreases in eating in much the same way we would other specific fears.
Okay, terrific. And I see there've been a number of folks in the chat that have asked how to find a doctor similar to Dr. Amy or someone that can do CBT. How do you best find that? And we have on the International OCD Foundation's website how to find resources. And I would ask the IOCDF if they could post that link in the chat, please. That would be great. Over to, okay, so great, that is back up in the chat. So that if you follow that link, you'll be able to put in your area where how far you'd like to be able to travel for that, and see if there's anyone that is specializing in this in your area. I have a similar question, Dr. Young, that I'll follow up with a 758. But a question: I'm a 17-year-old with major anxiety, doesn't want to go to school, doesn't want to participate in any favorite sports or even friends, won't respond to anyone, any recommendations. And so this is unrelated necessarily to Pandas, but certainly in the same venue that many of our parents are dealing with.
Sure. So absolutely, so many recommendations. Having the child, if willing, to start with an appropriate psychologist, working with the family. Again, what we're doing is we are looking at graded exposure and perhaps even what we call some behavioral activation in this situation, which is in many ways very similar to exposure therapy, looking for things that had brought on pleasure and a sense of mastery, and beginning to slowly integrate those things into the child's life. Looking at some of the cognitions that they might have around that, if there's depression, if appropriate, a medication consult, looking at systemic issues, consultation with the school, just a variety of things like that.
Is there a difference, if I could ask the group, between social anxiety, OCD, and Pandas?
Yeah, absolutely. So there is a distinction in the DSM, although as an anxiety and OCD specialist, in many ways, we don't conceptualize it all that differently. We really go about things in the same way, looking at an obsession and a compulsion and an obsession and a compulsion and obsession and compulsion, and looking to treat those things. It really just has to do with the specific fear consequence. So traditionally speaking, with social anxiety, the fear consequence is a fear of judgment and what will people think. Whereas a specific fear consequence in OCD can vary, significantly. We see a lot of overlap in those things. One of the academic distinctions in some ways with OCD is an intolerance of uncertainty, a stuckness in the thinking, and sort of that repetition, like you said, with your daughter saying, "I love you, Mom, I love you, Mom." So there's a repetitive quality to it, sort of a flypaper in the brain, if you will. And then certainly with PANS and Pandas, we look at an environmental insult, at a infection or virus, as opposed to traditionally the way we think of classic OCD and social anxiety, having a little bit more of a genetic loading, particularly when it comes to OCD, and that it's socially learned and conditioned.
Okay, great. So we have about 9 more minutes, and we're going to keep going with questions. But we do have a follow-up that I think we're going to do. And Kyle, I think you had volunteered to be on this with me. We do not have the time for it yet, but in a couple of weeks, we'll do an Instagram live where we will capture a lot of the questions from this chat that did not get answered, and we will try to provide sort of more general answers to some of those specific questions. Mm-hmm. Kyle, still okay with that?
Mm-hmm. Yeah, definitely. And I mean, I think I know how frustrating this can be for parents to not have. I just wish we had more answers and specific. So people are asking about tick-borne illnesses, the length of treatment for antibiotics and anti-inflammatories. All of these different things, and they're all the most appropriate questions you could ask, and we have very little data on them. as far, so for long-term follow-up, for, it's kind of like the three, I kind of refer to them in clinic as the three questions. It's like, why did this happen? What's the best thing to do? What's going to happen in the future? And we don't have those for PANS and PANDAS. So I wish we did. The majority of the kids that I feel like we see who we're able to treat in some, way, shape, or form where their symptoms get better, they do really well long term. So yes, we do see people have recurrences later on. It's not. I wish that it was sort of like completely gone and we could close the book on it. But I do think that the majority of the people that we see, this is a time-limited illness in childhood, and as they get older, they do better. But there are obviously exceptions. But what we just need to follow this for longer to, I think, be able to say that that's 80% of the population versus 50%.
All right, terrific. So if your question doesn't get answered tonight, do not despair. We will try to get Instagram, and we'll advertise that out to on Facebook as well to let you guys know when that will be. I'll invite Dr. Young and Dr. Rice if they're available to participate as well, or to submit some answers. We'll put those together in writing, and then Kyle and I will have a conversation at minimum. All right, so I think there's a really great question for this moment in the call that happened at 8:15. Basically asking if we just go over for a general pediatrician or for parents, the first steps if you think a patient or child has PANDAS or PANS, and what treatments to try before IVIG. I know we've touched on it before in the call, but I want to make sure we're ending with that because it's easy to have a lot of conversation about IVIG and other major medical treatments, but what are really the first steps that we do?
So I'll take that one. And we can share, our group has put together some first things. Stanford has done the same thing. Both Stanford and the University of Arizona have put together what should you do as a pediatrician. The first thing is to listen to the parents and acknowledge that this is a real thing. The next is to look for an infection, and if it's possible to treat that infection, to identify it, if that requires cultures, whatever it requires, to identify the infection, to treat the infection. And then our first line comes out of work that has been mostly through Stanford, looking at the use of nonsteroidal anti-inflammatories. And as Dr. Williams said earlier, we typically use naproxen because it's an every 12-hour medication, whereas ibuprofen is 3 times a day. The reason we do use ibuprofen is that there are a lot more palatable forms of ibuprofen. They're more flavored, there's chewables, it's easier to get it in younger children. So we'll use one of those two. And then we're just going to keep ramping up. But I think that those are that's the way that a pediatrician could start. Then, I would refer to the PPN, the flow sheet, and look at either the University of Arizona or Stanford's What to Do with Your First PANS Patient. We both have them, and we share back and forth all the time. I think one of the important things for people to know on this call is that all of the different institutions who do this work across the country, we all know each other and we like each other, and we share quite freely. We call each other up to ask for help, or we have calls and meetings on Saturdays sometimes. So, we're getting together and sharing information. We're good friends. So you have a team of people across the country who are trying to do everything we can to help.
Sometimes people will ask me if I'm sure that PANDAS or PANS is really a thing, or how would I address someone that says it's controversial. And I usually just look at them and say, I'm pretty sure that Columbia, Stanford, Harvard, University of Arizona, University of Tampa, Yale would not be doing research on an illness that did not exist. All of those very prestigious research universities are deeply involved in doing this research, and they all work together. It's really an amazing group of folks who are genuinely in it for your kids, to understand what's happened to them, to understand what to do best for them, and to understand what the long-term prognosis is for these kids. But I want to say to you from the International OCD Foundation that we really do send out a lot of hope to all of you. There is very good treatment in the psychological treatments that Amy has been talking about here with all of you, as well as many of the medical treatments. So while we may all be walking in a time where the science is not yet 100% clear, there are lots of options for your kids, and we hope that we'll be able to help. I had a question at 8:22 for you, Dr. Young. Do you offer teletherapy? Are there any listed therapists with a good understanding of PANS and PANDAS who offer teletherapy? So first of all, I'll ask the IOCDF to stick back up their Find Help link again and answer to that question. We do call out with a lot of the folks if they do teletherapy. But would you like to answer that question, Dr. Young?
Sure. Yeah, a lot of practitioners are offering teletherapy. I would definitely direct them, as you said, to the IOCDF, Find Help, Find a Therapist. Link, I think many people are providing. They are limited to be able to provide teletherapy within their states that they are licensed in.
Yeah, and so every state has slightly different rules about that, as well as different practitioners may have different caseloads and abilities to pull that in. But we do have a very good list of folks who can help. So we hope you'll look for those resources there. We had a great question again for Dr. Young, sticking on sort of the psychological side of things at 8:21 from Michelle. For OCD, writing it down instead of stating it verbally eases my kids' verbal OCD tics. Is this okay?
So for OCD, writing it down instead of stating verbally eases my kids. I guess it depends. I'm not entirely sure, what would be the exposure and what would be the compulsion in this situation. So, oftentimes when I'm training staff, if they're unclear what to tell the client to do, oftentimes doing the opposite is a good strategy. So for one person, what might be a compulsion, for another person, might be a compulsion. And we would go treating. I'm not sure if the question is a little bit about OCD or about tics. And as another FYI, there can be something called Tourettic OCD, which seems to be the combination of those two. So in many ways, I would say oftentimes if you're really in question what to do, chances are doing the opposite of what the child prefers or what the anxiety is telling them to do is probably a good direction to go in if you're not sure.
So we are going to capture the rest of the questions here, and we will announce when we're going to do our Instagram answer on those as soon as we can. I would like to thank the wonderful audience we've had here today. So many questions. Really, really appreciate all of your interest in Pandas and PANS. And I would especially like to thank our panelists, Dr. Williams, Dr. Rice, and Dr. Young. It has been a pleasure to be here with you tonight, and I really appreciate your time. Thanks for all you're doing for our kids.
Thank you. And I would, if anyone's looking for information on the IVIG trial, I think go to our various websites.
I sent it in the private chat, and maybe we can share it, pop it over. I sent in 2 links. One is on the clinical trial, which will tell you all of the tools that are used. And then one is a link to Octapharma that gives you a name and a phone number to call to find the site that is closest to you.
IOCDF team, would you mind posting that up in the chat so that will be saved? There we go. Done. Dr. Rice, see how efficient we are.
All right.
Many great teams behind the scenes. I think we have 3 folks from the IOCDF tonight. I just want to say thank you so much for being behind the scenes, and Vicki from Pandas Physician Network as well. For helping all of us answer the questions and just stay organized. So thank you so much. Thank you everyone for participating, and we'll see you on the next one.